I'll work through this outline. First, we'll define what shock is and describe oxygen delivery and how our body compensates for shock and abnormal delivery of oxygen. My biggest goal is that viewers understand the relationship between blood pressure, cardiac output, and SVR, and use that as a framework to understand the three core categories of shock. And finally, once you can fluently go through the categories of shock, you can quite simplistically use simple physical exam tools to determine how you are going to manage the patient that presents with shock. Shock, quite simply, is when the body is not delivering enough oxygen to a given cell. It is deranged perfusion, and it leads to cellular hypoxia. It's really more than just oxygen, although the central tenet of shock is impaired oxygen delivery. We know this because studies that looked at hyperbaric oxygen chambers really didn't fix shock states, despite an adequate PaO2 that would deliver oxygen to cells appropriately. The deranged perfusion of shock can be systemic, as in the entire body has poor oxygen delivery, or regional, just to certain organs, or even sections of the body, like the arm, if you have a tourniquet on too tight. All of shock results in not enough oxygen delivery, which means that the mitochondrial electron transport chain, the most efficient part of our body to make ATP, can't make it efficiently, and that energy production failure results in widespread abnormalities and changes in the body as it adapts and otherwise doesn't adapt to not having ATP. Uniquely, you can fix shock, but problems persist after you fix it, and this is due to the reaction to shock, which includes failure of the mitochondria and then delivery of blood flow to them, yielding reperfusion injury, massive oxidant production, and general inflammatory state and loss of the endothelial barrier. Oxygen delivery involves a simple mathematic equation. DO2, or delivery of oxygen, equals the carrying capacity of the arteries for oxygen times the cardiac output. Fairly straightforward. How much oxygen is in the blood times how much the blood goes round and round. The carrying capacity of oxygen equals the hemoglobin times the SAT times a ratio of how many mils of hemoglobin exist on each gram of hemoglobin, which is 1.34, plus a very tiny concentration of dissolved oxygen, 0.3% of the PaO2. Very small contributor. So the carrying capacity of oxygen is very much hemoglobin and saturation driven, with a small contribution of PaO2. And the cardiac output is straightforward calculation of heart rate times the stroke volume, heart rate being a straight number, and the stroke volume really being quite intensely variable based on the preload, how much blood is delivered to the ventricle, the afterload, how much resistance the ventricle has to pump against, and how strong the ventricle is at that moment, the contractility. Our body does a lot of things to help compensate for low delivery of oxygen or for shock. This is a common figure shown in textbooks. I happen to have cited a 2002 textbook below that refers to how the delivery of oxygen can yield problems as it decreases. I find it challenging to think through this slide because the delivery of oxygen going downward yields the changes, and that's leftward on this slide. So I just reversed the picture. And what you see is the light gray area has a VO2, the cellular respiration of oxygen. That doesn't change much in the light gray area over a wide range of DO2, or delivery of oxygen. And in that wide range of delivery of oxygen, so a low cardiac output to a very high cardiac output, the cells are able to compensate by extracting more or less oxygen from the blood that is going round and round. And so me sitting here, I use some percent of the oxygen that goes around my body, let's say 15 or 20%. If I were to develop CHF and drop my cardiac output, my delivery of oxygen would decrease. And my body's first approach, that's fairly straightforward, is simply that I would take more of the oxygen off the hemoglobin as it went round and around my body. That function of taking more oxygen off of the hemoglobin is called the extraction ratio. How much of the oxygen do you extract from your blood as it goes around and around? If you take more oxygen out, the oxygen level on the venous side of your body will be lower, and that's the SvO2, the venous saturation of oxygen. So those are just directly inverse. If you take more out, the remaining oxygen is less on the venous side. What we see is there's some critical threshold where the extraction ratio is closer and closer to being maxed out, and the cell's ability to respirate or use oxygen starts to fall off. And when that occurs, you have a cellular failure of ability to adapt to the shock state. And that means that the extraction ratio is so high it can't go up, and yet the cells still aren't getting the oxygen they need. And so there's simply not enough oxygen there. And in that window of time, the oxygen delivery is flow dependent. The cells are taking every bit of oxygen from the blood that goes by, and the only way to help is to give more blood and push more blood through. That's a flow dependent area. And as you hit that window, certain cells are going to not get enough oxygen, and they're going to rely on lactic metabolism or anaerobic metabolism with production of lactate. And so the lactate levels start to go up. As that occurs at the cellular level, our body does other things to react to the shock state. The autonomic nervous system starts to release catecholamines and make more catecholamines, and these impact our heart rate, our contractility, and our SVR, all of which to varying degrees will go up. This is all consistent with the fight or flight reflex. The renin-angiotensin and aldosterone system is activated, which results in salt water retention, increased sympathetic activity, and secondary water resorption because of the resorption of salt. The Arginine vasopressin system is really a last-ditch effort for the body to maintain blood pressure by causing arterial vasoconstriction when the blood pressure is low. And there are other mechanisms that our body compensates for shock states, one of which is the glycocalyx. All those things you learned about the Starling curve are really not very accurate. It turns out we have this little wall of sugars on the side, on the blood side of our endothelium, that holds about a half a liter of water to bolus to us if we are lightly dehydrated. And this area of the body also helps to keep proteins and blood in the blood vessels and not leaking out. And so when we have an endothelial failure, it causes dramatic disruption of this glycocalyx, which can cause widespread inflammation and problems. Going back to what I showed you earlier, just a reminder, the delivery of oxygen equals how much oxygen is in the blood times how much the blood goes around and round. It's important to know that while we really define shock by low blood pressure does not mean there's low blood flow, and shock is low oxygen delivery. What we really care about is cardiac output. There's a really critical mathematic equation to learn, and it's the top right one. The MAP equals the cardiac output times the SVR plus the CVP. There's some other math to make the numbers work and the units work out, but the relationships will hold true. If we simply ignore that in most people the CVP is not a major contributor to the MAP is about equal to the cardiac output times the SVR. And we know that the cardiac output is the heart rate times the stroke volume. If we rearrange that, what we see is the cardiac output equals the MAP minus the CVP divided by the SVR. That's what we really care about. But the way we practice medicine is blood pressure first. We're very good at measuring it. We measure it all over the place. And we're not very good at measuring cardiac output. And so we really use fundamentally is that top portion, MAP equals cardiac output times SVR. And it's a very important relationship to consider, because if you know that the MAP is, say, 60, low but hanging on, and they have cold extremities, you know the SVR is high. So for a given MAP that's on the low end of normal, if the SVR is high, the cardiac output must be low, and that helps us define our shock states and know what to do about them. Okay, so we can categorize shock into 3 core categories of things that make it much easier to work through when you're in an urgent situation, and it becomes challenging to think through a long list of possible diagnoses. My main big 3 categories of shock are preload problem, an afterload problem, or cardiac problem. The final category of shock is not something I think about as frequently because it is normally much more obvious, and that's critical anemia, hemoglobins in the 4s or 5s, that is not causing an acute hypovolemia, so oncologic patients, or critical hypoxia. And both of these situations result in a problem in the carrying capacity of oxygen in the blood. They're a bit more obvious diagnoses, but they can result in profound shock and end organ complications. Going back to my big 3 categories, preload, afterload, or cardiac problem. Preload problem is they're either dry, under-resuscitated, or bleeding, and this is a reminder to think about Starling's curve. Afterload problems or vasoplegia, vasodilation, can be caused by a whole bunch of things. I'm fairly convinced the most common afterload problem we have is an excessive use of sedatives, particularly in the intensive care environment. But certainly the most talked about etiology of an afterload problem or vasoplegia is sepsis or inflammation, inflammatory states. Septic shock, of course, can cause a whole myriad of different mixed types of shock, but and vasoplegia is the most dominant part of the physiology of septic shock. Finally, high spinal cord injuries will cause a lack of sympathetic outflow and a loss of vascular tone, and adrenal insufficiency will cause a deficiency in angiotensin II and resultant vasoplegia. Finally, cardiac causes are really diverse in nature. The most simple one to see and diagnose is a dysrhythmia because it's right there on the monitor. CHF or systolic failure can result either chronically or acutely from an MI or cardiac contusion. Obstructive etiologies are things you have to think about every time you have a patient in severe acute shock. Those are things like a pulmonary embolism, cardiac tamponade from bleeding or fluid, or a tension pneumothorax. And finally, while valvular disorders are thought about very frequently because they're very complex and take a lot of time to learn, clinically they are not seen as a frequent cause of shock on a regular basis. If we expand this list a little bit, I've just added some of the diagnoses and more specific etiologies of shock under each of these big 3 categories. And that really supports the idea that all of these causes can be reviewed really quickly at the bedside by saying preload, afterload, or cardiac problem, and then going through each one and why it is what's going on or what is not going on. When we look at these types of shock, we can use our monitors or really our physical exam to have an idea of what is happening by evaluating whether their cardiac output might be high or whether their SVR might be high or low. Remember that equation we went through earlier, the MAP equals the SVR times the cardiac output. If you can, at a given map, determine the SVR is high or low, or the cardiac output is high or low, you can figure out the other one by the simple relationship between the two. High SVR, or vasoconstriction, will give you really cold extremities, hands that are mottled, and weak pulses with a very long capillary refill time. The hands look white. A high cardiac output, on the other hand, or low SVR, will give you warm, hot extremities with flash capillary refill time, and a patient that looks like they're having a fever. They're pink or red with bounding pulses. If we go through and think through our big categories of shock and how they will look on physical exam, you can see very easily that we can differentiate the categories of shock based on physical examination most of the time. A patient with a preload problem will have a low cardiac output because they have not much blood getting to the heart, and they're on the shallow side of Starling's curve. They most of the time compensate with a higher heart rate, and they'll have a higher SVR because they're trying to maintain a blood pressure in the situation of a low cardiac output. And they'll have physical exam findings consistent with that high SVR, cold, clammy extremities with weak pulses and long capillary refill. A cardiac problem can look very similar, and you have to use your history and clinical suspicion to separate a cardiac etiology from a preload etiology. And to be honest, most of the time that's reasonably simple to do. And when it's not simple to do, you get an echocardiogram or obtain further testing or more advanced monitors. Afterload, or vasoplegic shock, has the opposite clinical situation: high cardiac output because the heart is pumping against a low resistance, and a low SVR, so flash capillary refill, hot extremities, red or pink appearance. And so you can use your physical exam in that relationship of MAP equals cardiac output times SVR to determine your type of shock most of the time. For a given MAP, if the SVR is high, the cardiac output will be low, and if the SVR is low, the cardiac output must be high. That can dictate your therapies appropriately most of the time. So I use this basic arrangement of preload, afterload, and cardiac problems, and I combine that with my physical exam, mainly by feeling the patient's hands, capillary refill, and radial pulses to determine my initial approach to a patient in shock. If I feel cold or shocky extremities, long cap refill time, I know the SVR is high and the cardiac output is low. In a typical average patient without a unique cardiac history or a reason that I should be thinking about the unique cardiac etiologies of shock, I generally will give a patient with high SVR a fluid challenge. If that doesn't work, or works only for a little and doesn't work on an ongoing basis, I think about an inotrope or a chronotropic agent like epinephrine or dobutamine. I try to wean the norepi if I can, and as soon as I can get the time to do it, I will perform an echocardiogram to determine what is going on with the heart of the patient that has low cardiac output and a persistent shock state. On the other hand, if a patient has a low SVR with flash capillary refill and is hot, they're vasodilated, and I add a pressor first line instead of pounding them with fluids that they'll simply pump out more and more. This presents a really simple, straightforward initial approach to a patient in shock that, to be perfectly honest, will work for you most of the time, even in a critical care career. It's fairly straightforward, it's easy to teach, and it works almost all the time. The more nuanced shock management is much more complex, takes a lot more time, and in general, we just fall back onto this anyway. So this is a quite adequate way to evaluate a patient in shock. If you are not successful, or if the shock state persists, what happens is a widespread cellular failure, because if you don't get oxygen to the mitochondria, that electron transport chain will not work effectively and you will not make ATP. This results in protein failure and cellular failure, and as that happens, the mitochondria start to fail because the mitochondria want to use oxygen and make ATP. When they fail, you utilize other ways to make energy, like anaerobic pathways that result in acidosis, particularly lactic acidosis. And you also induce enzymes like xanthine oxidase and others that, when you finally fix the shock state, end up spitting out reactive oxygen species with reperfusion and causing this massive oxidative stress and burden. And what's interesting about oxidants is that once your mitochondria start spilling out oxidants, those oxidants will go to nearby cells and make those mitochondria fail as well. And you end up with a widespread spreading inflammatory and oxidant process that results in a contagious mitochondrial failure. And finally, one of the core organs that's so susceptible to poor delivery of oxygen is the endothelium. And at the level of the endothelium, when you don't deliver enough ATP, you start to have a massive failure with fluid leak. You lose that protective glycocalyx, and you get a massive inflammation reaction and spitting out of inflammatory mediators. And along with that, you can get immune compromise and sludging and deficits both in activating your immune system as well as in transport of immune cells. And the endothelium, as we all know, is very critical to normal hemostasis. And so you can get a bleeding diathesis where patients will both bleed and clot. In addition to the endothelium and more or less individual cellular problem of shock, your organs are compromised. That can result in kidney injury, strokes, delirium, encephalopathy, myocardial ischemia and CHF, atypical arrhythmias that become challenging to deal with, and even other organs that rely on perfusion will get compromised, and you can have compromised blood flow to your gut, causing mesenteric ischemia or dead gut, and you can lose fingers or even whole limbs due to limb ischemia. So any organ can be damaged and injured by a shock state if you don't get